Thank you, Dr. Bhupesh, and some great talks already that you've heard in this session, and a really nice session from the perspective of the newer techniques in cornea. My topic is going to be about DMEK surgery, and though I think it's impossible to actually teach DMEK in 10 minutes, what I thought I'll do is speak to you about why it is important to start thinking about doing DMEK and start converting to DMEK, at least in a few cases, if not all. Well, I've listed the reasons down here, but I'm going to go through them one by one about why DMEK is potentially a better surgery than DSEK is. So for all of you who've seen OCTs after DSEK surgery, you know that this is not exactly an anatomically more natural surgery. So you're taking off lesser tissue, but you're replacing more tissue, whereas in DMEK, what you take off is the desmoid and endothelium, and you replace the desmoid and endothelium, so actually is much more anatomically natural. But probably the biggest reason why DMEK scores over DSEK is there is about an 8-fold reduction in the rate of rejection after DMEK surgery. And for this reason, even grafts that are high risk, say following post-penetrating keratoplasty, endothelial keratoplasty, DMEK probably is a better choice than doing DSEK if you can do the surgery, because it seems that these have greater longevity. Visual acuity as well, you'll see that a majority of patients after DMEK will actually be 20 by 20 with correction if they do not have any comorbidities. There are patients who go up to 2016. Now we've started doing DMEK with toric IOL, started doing DMEK even in patients who've had multifocal IOLs with great outcomes as well. This is not so for DSEK. The other advantage is the fact that you have a very predictable IOL power in DMEK. Following DSEK, you have about a 1.5 diopter of hyperopic shift, whereas in DMEK surgery, the average shift is only about 0.5, which is the reason why you can aim for emetropia or even for monovision following DMEK surgery. Visual recovery is also extremely quick and rapid following DMEK. So this is a patient who had PBK. This is pre-op pictures. This is on day 1. You can see a partial air bubble where the edema has already come down. And by day 3, you see that this patient already is seeing about 20/30, 20/40. So very rapid visual recovery, which is unlike any other keratoplasty procedure that we have in our armamentarium. Refractive predictability is the other important reason, because when you're trying to deliver your graft in DSEK surgery, the smallest incision that you can potentially make without hampering endothelium is about 4 to 4.5 millimeters, whereas in DMEK surgery, you actually can make an incision that is even smaller. Typical incisions in DMEK surgery are about 2.8 to 3 millimeters. There are injectors that go in through 2.2 as well, but may not exactly be the best idea. But the fact that this is similar to a cataract incision gives you greater control over the astigmatism that you will induce. There also are some differences in the surgical technique. The differences I'm going to point out very quickly. Like donor preparation, typically you do either a manual or a microkeratome dissection for DSEK surgery. Femtosecond laser is not used. In DMEK, nowadays in some eye banks in the US, you have pre-stripped rolls available. This is possible in India as well. And watch out for some news that you might be able to get pre-stripped DMEK rolls in the future as well. Donor prep in DMEK surgery is relatively simple, most of the time done by the surgeon himself in the operating room just before surgery. And this requires a little bit of skill, little bit of practice, but once you do about 5 to 10 cases, most of the times everybody can get a very successful desmoid membrane strip. This is just the process of creating the DM roll, and once you have the desmoid membrane completely stripped, it usually is very tenacious and doesn't tear or doesn't break very easily. The next difference in DSEK versus DMEK is the stripping of the desmoid membrane is not essential in DMEK, and even if it is done in a smaller area. Whereas in DMEK surgery, the stripping is very essential, because if you have overlap, then you will tend to have detachments, and the stripping usually is a larger area as compared to in DSEK surgery, because you do not want to have overlap between your graft as well as your host desmoid membrane. Incisions in DSEK surgery, they tend to be longer, and they also tend to make sure that they're self-sealing, because you want the graft to seal the incisions from the inside in DSEK. Whereas in DMEK, you do not want your graft to overlap your incisions. So in most cases, what you will be doing is very short stab incisions so that they don't go into the area where your graft is overlapping your internal ostiums of your incisions. This is true for the main incision that you make, and this is typically slightly shorter than the incision that you will make after in cataract surgery as well. And so by default, most incisions are made temporarily to give you more space in the anterior chamber. Marking the graft is not essential in DSEK surgery because most of the time losing orientation is very difficult. But in DMEK surgery, usually orienting the graft or identifying the correct orientation is difficult. So I always mark my grafts with an alphabet. In this case, for obvious reasons, I put a P. And it is quite easy to identify the alphabet once it's in the anterior chamber. As you can see, after the bubble is put in place, you can see the P very nicely there to know that it is in the correct orientation. Sometimes in corneas that are not very clear, if you can't see how the graft is unfolding, the letter is your only recourse to be certain of the fact that the graft is opened up correctly. Loading and injecting the graft in DSEK surgery, usually the graft is loaded with the endothelium on the inside. This is showing a Busin glide loading with the endothelium being curled inside as you load and inject your graft. Whereas in DMEK surgery, you really do not have control over how the graft will scroll, but it is known that almost all grafts will scroll with the endothelium on the outside. So this is DSEK surgery, and you'll see that the endothelium is on the inside as you deliver it. Whereas in DMEK, the scrolls that form always have the endothelium on the outside, and with that knowledge, you can go in and start to unfold your graft as you inject it inside the eye. Delivery for DSEK, you have several systems that are available right now, but in DMEK, most proven delivery systems are using glass tubes. There's several manufacturers right now, some local, some international as well, and you can choose the one that is preferred depending on the technique that you would like to use. Manipulating the graft in DSEK surgery is also very easy because once you get the graft inside the eye, then all you have to do is hold the graft and move it around if it's not very well centered. But in DMEK surgery, you can't do that because if you hold the graft and try to center it, then you're going to tear the graft. So this is a case of DSEK where I'm actually going in and touching the graft, moving it around, washing the interface, and then putting an air bubble. But in DMEK, almost all manipulations of the graft will have to happen remotely. That is, you will have to learn the technique of tapping, where as you tap, the graft tends to open up, and you also need to be able to predict the direction in which the graft opens up as you tap, and also to make sure that you tap it in the correct orientation and the correct direction so that your graft opens up in the desirable manner. If you tap in the wrong place, it is possible that your graft will actually flow out of the eye, but if you tap in the right place, it actually opens up very easily. So no direct manipulation and mostly indirect manipulation. Attachment of the graft is quite simple in DSEK, whereas in DMEK, you'll need to make sure that you have an air bubble that is inside the eye for at least 24 hours. So to summarize the conversion of surgery from DSEK to DMEK, the reason why is probably primarily because you have lesser rejections, so you'll need to use lower amounts of steroids, potentially also better visual outcomes. There are some difficulties during transition, but on average of about 10 cases or so should be good for you to become a good DMEK surgeon. There are still some cases where you'd like to do DSEK where visibility is poor if the patient has comorbidities, extensive peripheral anterior synechiae, poor posterior graft host junction, and where DMEK really will not give very good visual acuity. And the last slide that I'd like to leave you with is the fact that there are a few things that you have to unlearn when you're doing DMEK, unlike DSEK. To remember that DMEK grafts can tear, unlike DSEK. Avoid all direct contact with your DMEK graft because it actually is going to damage endothelium. Use fluid waves rather than touching the graft at any point of time. Center the graft before you actually start to attach because once you attach, you can't center it again. If there are folds, you need to detach the graft and then reattach it again, unlike like a LASIK flap. And air bubble management or learning how to use the air bubble is going to be really important to ensure that you have a predictable surgery. Thank you very much.
Thank you, sir. Thank you for the wonderful video of DMEK surgery. I just have a question for you, sir. In case of, what about the incidence of rebubbling in DSEK versus DMEK?
We looked at our series. The incidence in DMEK is slightly higher than DSEK. Incidence is about 5% or less is what we have. We use only air, we don't use SF6. 5% is pretty low, but we tell all patients that expect a rebubbling in case that you need to, and they're quite okay.
And what could be the reason for this, for the higher incidence in DMEK?
Reason is because the tissue is naturally scrolled, whereas in DSEC you have the tissue that is the same curvature as your cornea, so it tends to attach, surface tension helps it, whereas in DMEK it's like a dog's tail. It tends to always scroll according to its original configuration.